Our speaker today has no personal, business, or financial conflicts of interest to report. Dr. Rupali is an assistant professor of medicine in the Division of Cardiology, the College of Medicine at UAMS, and a staff cardiology at the Central Arkansas Veterans Healthcare System. And he is going to talk today on cardiac arrhythmias and the aging heart.
As Dr. Chernoff noted, I'm a full-time VA cardiologist. I work 20% of my time at UAMS. I have a clinic on both sides of the street. My primary interest is actually echocardiography and valvular heart disease, but anyone who's been in a clinic or in a hospital in the 21st century knows that cardiac arrhythmias are really the most important reasons for admission or cardiac disease in the elderly. 10, 15 years ago, our cardiology wards used to be filled with patients with coronary artery disease and MIs. Now they're filled with patients with arrhythmias and congestive heart failure. So cardiac arrhythmias, I think, are so common that everybody, cardiology, medicine, nursing, pharmacy, everybody, I think, needs to have a general understanding of cardiac arrhythmias, the most common ones, and how do you deal with them in the setting of an aged heart. So that is the topic of my presentation today. And these are my objectives. We'll briefly discuss changes in the aging heart, how the heart changes as one ages, and how that can lead to common arrhythmias. And then what we're going to do is we're going to hone in on a few of the most common arrhythmias that you will see day in and day out in the clinic or in the hospital. We'll talk about what's already known, we'll talk about what's new, and we'll try to discuss it in a very clinically useful manner, because something that you can take back and start using in your clinic. This will be the outline of my talk. Like I said, just a few aging-related changes. We will spend a lot of time on atrial fibrillation, because that's easily the most common arrhythmia, old or young. We'll spend some time on bradyarrhythmias, because those questions seem to come up a lot in how do we work this patient up who has a slow heart rate. And more importantly, I'd like to leave a lot of time for questions, because the topic is vast. I do not pretend to make you experts in this entire field in 1 hour and 40 minutes, but I think with sufficient time for questions, I hope to be able to answer any questions that you may have. If you look at a heart of a young person or animal versus an old person or animal, or a person or animal that has aged, there are distinct differences. This is the ultrastructure of the myocardium at its most basic unit. You have myocytes. Between the myocytes, you have fibroblasts. There is a little bit of collagen just to hold all these together, okay? And the collagen is really not that much. And you have capillaries, which provide blood flow. As the heart ages, chronologically, because of risk factors, what have you, as the heart ages, you notice that the myocytes start becoming bigger. They hypertrophy. The collagen starts getting deposited in more abundant quantities. Okay. The fibroblasts turn into what are called myofibroblasts, almost as if they're trying to compensate for the hypertrophied, inefficient myocytes. And there is a lot of fibrosis that is laid down. Now, these are two sections from a young mice and an older aged mice, and you can see distinct differences. Here, the myocytes form the predominant population of cells. They're smaller, they're not as hypertrophied. The red would indicate collagen. There is very little collagen in between the myocytes, whereas when one ages, the myocytes become hypertrophied, and there is a lot more collagen that gets deposited between these myocytes. Okay. Now, what causes this? What are the factors at play which lead to something like this? And this is an excellent article in case someone is interested in reading about the genetic and the environmental factors that affect aging. This cartoon basically gives us all the different things that can happen with aging. Okay, and it also gives you the genetic basis for some of these changes. Now, let's start off with something that we all easily understand. Apoptosis, or just the general natural cycle of cells dying down because of age. That is one of the common processes that happen in the aging heart. The fibrosis we already looked at. We see how the myocytes become hypertrophied. There is a lot more fibrosis that happens. There is hypertrophy again. Senescence, that's again something we understand, that as the cells grow older, due to certain genetic influences, these myocytes again become inefficient, a lot of fibrin deposited in between. There is ischemia. As one goes older, there is more ischemia in the heart, either because of something we understand all the time, which is a blockage in a coronary artery. Okay, coronary artery disease, 70-80% blockage in an epicardial coronary artery. That is the thing that we often think of. But despite having normal coronary arteries, there can be ischemia at the myocardial level because the capillaries that we saw in the earlier slide, they may be relatively ischemic. This is so-called microvascular dysfunction. The epicardial big pipes going down to the heart muscle are all open, but there is dysfunction at a more myocardial or a smaller at the cellular level, which can still lead to ischemia. As a result of all these changes, and due to certain genetic influences, and you'll hear me use this word genetic influences a lot, because remember, not all of us age the same way. There is certainly an amount of genetic influence. There is, of course, the environment, which determines how we age. But basically, because of all this and certain changes in the genetic structure, you start seeing changes in the conduction system of the heart, which can lead to arrhythmias. Now, most of the time when we think about the heart muscle in aging, we just look at the heart itself, and we fail to understand sometimes that the vasculature plays as big of a role in aging the heart as the heart itself. So what am I talking about? I am talking about as the blood vessels age by themselves, they become stiffer. There is atherosclerotic plaque that's deposited within the blood vessels. Remember that the blood vessels in the heart are akin to a motor and a tube that's attached to a motor. If your tube is too small and your motor is efficient, it would still not be able to pump as much blood through the heart. And in fact, you could argue if your tube is getting smaller and smaller, that the motor may actually burn out because the resistance is too high. And that's another important concept to understand as far as the heart is concerned, is that the vasculature and the coupling between the heart and the vasculature also determines how the heart ages. And these are, again, some genetic influences that promote aging and promote cardiac dysfunction related to vascular dysfunction. So these are all the processes that happen as one ages to the heart itself. Now, aging, I said, is not a chronological problem. There is probably something called cardiac age. And this was validated in the Framingham Heart Study. They came up with, how can we look at the cardiac age based on how well people do without cardiac problems as they age? And they came up with a calculator. It's easily accessible. It's on the CDC website. And a few years ago, the CDC kind of analyzed a population, a representative population in every single state, and said, what is the heart age per state? Are certain states more healthy? And going along with what we already know with several other diseases, you can see that some states seem to age better than others. So here we are, including Arkansas in the South, Mid-South, where our hearts are probably older, at least 5 years older than our chronological age. Whereas in states like Colorado, California, younger, fitter states with less obesity, the heart age seems to be, people's hearts are younger than their stated age. What goes into these calculators is very simple things. Body mass index or obesity, hypertension, cholesterol, and your own age, simple stuff like that. So remember that as these diseases pile up, as obesity increases, the heart ages at a pace that's much more than your chronological age. And this is so important in clinical cardiology. When we see a patient in the clinic, the age that's on the chart probably does not represent how a person's heart is. I've seen plenty of 60-year-olds whose heart, when I do an echo or when we do an angiogram, which looks like, I don't know how we could say it, but we commonly say it looks like a 90-year-old heart, and You wouldn't imagine how many 90-year-olds walk into my clinic who are fit as a fiddle and can do pretty much anything they want. So I want us to remember that age by itself should not influence us. It should, but it depends on how the person's doing, how the risk factors are, as we decide how we need to treat some of these arrhythmias. And that's why I want to just show this slide to show that aging is not just a chronological process. Now, we looked at some of the fibrosis, apoptosis, senescence that happens in the heart with aging. What happens to cardiac electrophysiology? And I promise you after this we'll delve right into the clinical aspects of this talk. Now, as the heart ages, this is the normal cardiac conduction system. It's a little small, but I hope all of you can see it. So the impulses start in the sinoatrial node. That's the sinus node, that's the pacemaker of the heart. They travel from the sinoatrial node to the AV node, or the atrioventricular node. There it goes down the His-Purkinje system, which sends that impulse down into the ventricle. So it's a nice intricate dance where, if you imagine my left hand down here as the ventricle and my right hand as the atrium, an impulse that starts in the atrium, causes contraction, goes down into the ventricle, and causes a synchronized contraction in the ventricle. So this intricate dance is affected in aging. And at what level is it affected? It's affected pretty much at every level. The most common thing that happens is the number of cells in the sinoatrial node start decreasing by fibrosis, apoptosis, and the most common thing we see is that the sinus rate decreases as one ages. With that, it's not just the resting heart rate, but as people walk, their heart rate fails to go up as much as they would have when they're old. Now, some of you who look at stress tests and stuff like that, you would realize that when we talk about a target heart rate, we say 220 minus age. And the reason we say that is as one ages, we do expect that your target heart rate is not as high as a 20 or 25-year-old person because of these changes in cardiac electrophysiology. Now, below the sinoatrial node, there is fibrosis and calcification, which again, going back to our little slide on all the processes that happen is no surprise. So there is fibrosis and calcification down into the ventricular conduction system as well, because of which you may see things like right bundle branch block, you may see that the QRS gets wide, and you could see arrhythmias starting from the ventricle itself. But really, the most common arrhythmias that happen in the aging heart happen at the level of the sinoatrial node and the atrium. So that is what really we'll concentrate on to a much greater extent today. The most common arrhythmia we see, by far, not young or old, is atrial fibrillation. It's a significant cause for hospitalizations. It's a significant cause for morbidity and mortality. Some of the morbidity and mortality is due to the disease itself. Some of it, unfortunately, is our treatments that we use for this disease. And that is what I hope to concentrate on to some extent during this talk. And when a patient with atrial fibrillation is hospitalized, it increases length of stay. Doesn't matter if they're admitted for a hip fracture or what have you, just having atrial fibrillation is just a bad thing. Okay. What happens with atrial fibrillation? Now, this cartoon here, I won't go through all of this, but it conveys a very important point. Atrial fibrillation happens when the sinus node is no longer the pacemaker that governs the heart. There is abnormal fibrillatory activity in the atrium, and there are different mechanisms by how that happens. The most common mechanism is an abnormal impulse starting from the pulmonary veins. These are the 4 pulmonary veins that enter the left atrium. Some people are born and some people develop they have genetic predisposition to having an abnormal focus in those pulmonary veins. They fire, and that takes over from the sinus node. When it does fire, the most important thing in this cartoon I would like you to concentrate on is there are numerous fibrillatory impulses throughout the atria. So it's just like instead of the atria contracting this way with sinus rhythm, the atria is just doing this. It's just fibrillating because of all of these different impulses that are happening in the atria. This is important because you can imagine if I don't have a single thing, a single pathway that I could target, trying to take care of this at a structural level or at a substrate level is going to be very tough. Meaning, there is not something I can put in a catheter there and magically eliminate, because there are just so many different foci within the atria. And that is something that will play throughout the talk here when we try to talk about what atrial fibrillation causes and how we treat it. What causes atrial fibrillation? A lot of it is what we already talked about. We talked about fibrosis, we talked about ischemia, we talked about apoptosis in the left ventricle. Basically, it all starts off probably because of genetic predisposition. Not everybody gets atrial fibrillation. Not everybody with hypertension gets atrial fibrillation. So probably there is a genetic predisposition, and then you start adding environmental factors. And what are these factors? Advanced age. Easily, aging is the single most important risk factor for atrial fibrillation. Hypertension, obesity, all the things that go into our cardiac age that we saw about. Metabolic syndrome, which is basically a state where you have insulin resistance, elevated triglycerides. These are all predisposing factors. This we already talked about as to where when the ventricle becomes stiff, instead of blood flowing out into the aorta itself, some of that pressure is transmitted into the atrium. Okay? So when you have increased pressure in the ventricle, there is increased pressure transmitted back into the atrium. Because of that, the atria, which are supposed to be thin, contractile structures, start becoming bigger in size. And as they get bigger, fibrosis happens within the atria, and whenever there is fibrosis, arrhythmias follow. Okay? So this is how the risk factors that we have, obesity, sleep apnea, hypertension, predispose to atrial fibrillation. The other things on this side of the chart are less well understood. We understand inflammation and oxidative stress less well because probably where they play a role is we often see patients who are admitted to the hospital with, for a surgery. They have inflammation going on because they are in pain, someone just cut their body open and sewed it back up, and that by itself can provoke atrial fibrillation. So you still need a substrate. That just increased inflammation and oxidative stress by itself may not cause atrial fibrillation, but in general, the whole package predisposes one to atrial fibrillation. Now, this structural substrate then needs triggers, and these triggers could be anything. And this is, again, people in the clinical realm see this all the time. When the potassium gets lower, when people are under stress, post-operatively, we start seeing a few ectopic beats, once in a while, extra beats starting from the atria. They capture this focus, and atrial fibrillation ensues. So it's important to realize that you need the substrate and you need the trigger. Just having one or the other does not make you have atrial fibrillation. So when you talk about atrial fibrillation, I think it's important to understand, in addition to the triggers and the substrate, that there are many things we just don't know much about. There are distinct gender-based differences in every arrhythmia that happens with aging. If you look at this table here, you see that men have more atrial fibrillation. Now you could argue that, men they have more hypertension, they may have more coronary artery disease, but we do know that women live longer, right? Women live longer than men. So even then, accounting for that, it looks like men are just more predisposed to developing atrial fibrillation. Okay, I want you to concentrate on under the women's tab, this particular problem here, where women, though they may have less incidence of atrial fibrillation, seem to be more affected by the side effects of the drugs that we use. And in fact, even though that's not the topic of this talk, this was a paper I wrote with my colleague, Dr. Padak, titled exactly this: Gender Differences in Cardiac Arrhythmias in the Elderly. I would refer you to that because women seem to be more prone to the side effects of pretty much everything we do. Pacemaker implants, cardioversions, antiarrhythmic drugs, and we just don't understand why, but I think that's something to keep in mind as we go along with this talk, that gender plays a role in the incidence and how people react to having atrial fibrillation. Now, when we talk about atrial fibrillation, I just want to make sure all of us are on the same page. Now, people have at least two distinct kinds of atrial fibrillation. Some people will have atrial fibrillation that happens, bothers them for an hour or two, and then they go back into sinus rhythm. That's called paroxysmal atrial fibrillation. If someone stays in atrial fibrillation all the time, they probably have what's called persistent atrial fibrillation. The reason I bring this up, even though it's not in the talk, is when we chart in the clinic or in the hospital, this causes a lot of confusion. We often see charted atrial fibrillation, that's it. That doesn't tell anybody whether the patient is in atrial fibrillation right now. Do they have paroxysmal atrial fibrillation? And we did something like cardioversion or put them on medication and they're in sinus. So I would encourage you, just in a clinical realm, to always use atrial fibrillation carefully so that you convey the message. I would do something like, if a patient has paroxysmal atrial fibrillation, just happens once in a while, I would say paroxysmal atrial fibrillation. If a patient had atrial fibrillation for a long time, we took care of it, and now they're in sinus rhythm, I would say atrial fibrillation, post-cardioversion or post-medication, currently in sinus. That gives a lot more understanding and makes everybody in the clinical realm know exactly what we are talking about. Because if I see a chart saying atrial fibrillation, I know nothing about what the patient's in right now. So I just thought I'd throw that out there as a means of making all of us communicate more effectively through the chart. So when you have a patient, you have an aged elderly patient who has atrial fibrillation. These are the things that go through everyone's mind when you're dealing with a patient like this. Should we keep them in atrial fibrillation and control the rate, or should we convert them to a sinus rhythm? Okay? So if you decide to keep them in atrial fibrillation and control the rate, that's called a rate control strategy. If you decide to get them into sinus rhythm, it's a rhythm control strategy. Okay? That is one of the first things we'll talk about. Then we'll talk about how do you best control the rate. We'll talk about anticoagulation, which is a huge issue. And we'll talk about the role of ablation and some newer procedures that are happening. So, you have a patient with atrial fibrillation. And your question is, do I leave this patient in atrial fibrillation, or do I do my best to convert them to sinus rhythm? And that's usually done by what's called cardioversion, applying a current to the heart, jolting it back into sinus rhythm. Or should we just control the rate? Do we know which one's the best strategy for our patient? Fortunately, this has been answered in one of the landmark trials in clinical medicine called the AFFIRM trial. It was published in the New England Journal of Medicine. They took about 4,000 patients, not really that symptomatic. Some of them were staying in atrial fibrillation all the time, persistent. Some of them were going in and out of atrial fibrillation, and said, we're going to divide them into two. We'll just put half of you on rate control medications. So if you go into atrial fibrillation, your rate doesn't go up too high. The other, we're going to use antiarrhythmic medications. What did we find? We found that leaving patients in atrial fibrillation with your rate controlled is as good as trying to get people out of atrial fibrillation and using dangerous medications to keep them in sinus rhythm. Okay? The medications we use to maintain sinus rhythm are called antiarrhythmic medications, and one of the dictums in clinical medicine is all antiarrhythmic medications are proarrhythmic. They are supposed to treat arrhythmias, but they can have other effects on the heart which makes them more prone to arrhythmias. So this is part of the reason why in this study, rate control, meaning leaving people in atrial fibrillation and just treating them, looking at their stroke risk, putting them on anticoagulation, is as good as keeping them in sinus rhythm. Now, that being said, not every patient with atrial fibrillation is the same. Some patients are very symptomatic. You will see patients coming to the clinic who have no idea that you check their pulse, it's irregular. You do an ECG, atrial fibrillation, and you say, have you noticed anything in the past few years? They'll be like, nope, I've done everything the way I would. They are truly asymptomatic patients with atrial fibrillation. Now, those patients will do just fine on rate control medication. We assess their stroke risk and put them on anticoagulation to reduce that stroke risk. There are some patients who will know exactly the time they went into atrial fibrillation. They're very symptomatic. They can feel their heart racing. They get short of breath. Those are patients who probably deserve a strategy where we keep them in sinus rhythm. The second important cohort where we need to think about getting them into sinus rhythm are people with congestive heart failure. This is a controversial topic, but when you see these people in the hospital coming back over and over again with more and more exacerbations of congestive heart failure, you realize that the atria not working well can actually decrease cardiac output. So going back to our little hand puppet show of the atria and the ventricle, remember we said the atria contract and then the ventricle contract. So the atria contribute about 10-15% of your cardiac output. When the atria are fibrillating, you lose about 10 to 15% of your cardiac output. In most people, you won't notice the difference. Some people whose hearts are not healthy, whose hearts are already very stiff, they depend on the atria to really squeeze hard to get blood into the ventricle, which will then go out into the body. These are the patients who will not tolerate losing their atria. So instead of the atria really squeezing nicely into the ventricle, now the atria are just doing this, and they will know. They often end up in pulmonary edema, they'll come to the hospital, and you know that this is a patient that we deserve to keep in sinus rhythm. Okay, so that would be the second cohort. The third cohort is rare, not as rare if you actually look for it. This is the cohort where the atrial fibrillation actively harms the cardiac muscle. This is called tachycardia-mediated cardiomyopathy. We have a registry going on now, not a registry, but a retrospective study going on now at UAMS. We see this reasonably often. What happens is our God-given heart is just tuned to being in regular rhythm. In some people, it's more so than others. So the minute your heart does not beat regularly, the minute it starts beating irregularly, the heart muscle seems to lose contractility. The heart starts to balloon up, and you end up in heart failure from the atrial fibrillation, meaning the minute you get them out of atrial fibrillation, the heart is now pumping normally. This is quite rare, at least if you read the literature. We see probably 2-3 cases of this at UAMS a month. These will be 45, 50-year-olds. They'll come in with profound heart failure, no heart failure in the past. They're in atrial fibrillation. You look at their echocardiogram, the heart's barely contracting. We say, let's get this patient into a normal rhythm. We do. We shock the heart back into a regular rhythm. We put them on a medication. We repeat an echocardiogram, say 2 months later, now their heart is beating normally again. So the atrial fibrillation was actually causing the congestive heart failure, not the other way around. These are probably people that, all these three groups are people that we should strive for sinus rhythm. And sometimes you would not know if this case really is a tachycardia-mediated cardiomyopathy unless you actually got them into sinus rhythm. So we really, in this day and age, when I talk to residents and students, they always seem to snicker when I say this. Even in this day and age, with all the technology you have, you still have to use your clinical acumen, your gut instinct to say, this is someone who may benefit from this, because we just don't know enough about all of these diseases we have. And if we have enough suspicion that the atrial fibrillation is causing the heart failure, we should make sure we give a trial of sinus rhythm to see if the heart contractility improves. Now, then comes the toughest part. Okay, we said rhythm control. How do we choose these medications? And are these medications safe? And what kind of effects can an elderly person can expect from medication like this? Now, this algorithm is from the 2014 ACC-AHA guidelines for the management of atrial fibrillation. We're not going to go into each of these individual drugs, but I want to point out certain salient points. And I think these are very important for everybody involved in a patient's care to keep in mind, because remember, when we start a medication, we started based on the information we have at that point. Things change as you follow a patient along. And unless you're constantly thinking about what has changed, you may leave a patient on a dangerous medication that we should have stopped. Okay? So let's look at how you choose a drug for maintaining sinus rhythm in a patient who had atrial fibrillation. If you have no structural heart disease, meaning your heart muscle is not thick, you haven't had a heart attack in the past, your LV contraction is normal, you have multiple choices. Okay? The drug that you see commonly used all the time is amiodarone. It's probably the most commonly used drug for atrial fibrillation. You see that if you have no structural heart disease, and you're trying to maintain sinus rhythm, amiodarone is probably the fifth or sixth choice. You have several other choices to maintain sinus rhythm, okay? But just watch what happens once you develop structural heart disease. As you age, say you had a heart attack. You were on one of these medications like flecainide for 10 years, and now you have a heart attack. You should not be on that medication anymore. Because remember, all of these antiarrhythmic medications are pro-arrhythmic on their own. So this would be something I would keep in my mind every time I see a patient with atrial fibrillation, whether they're managed by an electrophysiologist or anybody. If I see that, yeah, they've been on this medication for 10 years, but why? Now they have heart failure. I would make that phone call saying, we need to stop this. We need to switch to another medication which is safer. And I think that is easily the most important point in this chart, because most of us will not be starting these medications. We'll be seeing patients who are already on these medications show up in our clinic for related or unrelated issues. And I think all of us should be looking at the medication chart, seeing, is this really a safe medication for this patient to be on? And this goes along with that. And you see how when you have structural heart disease, amiodarone becomes very, very important drug, because that's one of the few drugs we have that we can use with structural heart disease. Now, amiodarone is a drug that has side effects from head to toe. If I put in a slide here with the side effects, I probably need 10 slides. So these patients need to be very carefully followed by preferably a clinic or a doctor who does this a lot of times, meaning a cardiologist, I think, or something like that, where you have a program where you're watching for side effects. Because remember, all of these medications can actually harm the patient if you don't monitor them well. Okay? So, and in this algorithm, you see you have something called catheter ablation. And we will discuss that in a future slide as to where you can actually try to eliminate atrial fibrillation by going into the heart and trying to modify the substrate, so to speak. Now, we made our decision. We said rhythm control or rate control. We said the patients who have rhythm control, we're going to start them on rhythm control medication. They'll probably follow up with an electrophysiologist most of the time. The biggest chunk of population that we will see in our clinics are the people that we say they're not really that symptomatic. We are going to elect for a rate control mechanism. Then the question becomes, okay, I'm going to control the rate, but what's our target? And believe me, this single topic is the source of so much anxiety in the hospital, in the clinic, because not anxiety for the patient, most of the time they're asymptomatic. It's anxiety for the doctors and the nurses and everybody involved in the care. You won't believe how many times we get phone calls all the time. Well-meaning, because there is this common conception that if you let a heart rate, if you let atrial fibrillation go uncontrolled, I've heard all kinds of things. It could cause a heart attack. It could cause heart failure. I said conception. I didn't say misconception. I said conception because the heart failure may probably be true in a small percent of people, but in most circumstances, we don't need to be as aggressive on rate control. And this is something we struggled with for a long time, but fortunately, there has been a large study which has answered this question for us, and that is what's called the RACE-2 study. In this study, what they did was they took people who are not really that symptomatic, and they said, we're going to divide you into two groups. One group is going to have lenient control, meaning we're going to see you in the clinic. If your heart rate is less than 110 beats per minute, we're done. Whatever rate controlling medication we have you on is sufficient. The other group was what was called strict control. Your heart rate had to be much lower at rest. We made you walk around, we put you on Holter monitors, and made sure even with exercise, your heart rate's very, very tightly controlled. Okay? And what did this study show? It showed, this is the x-axis is a months of follow-up, and the cumulative incidence of primary outcome is death, MI, that kind of stuff. What it showed really is lenient control, meaning letting a heart rate below 110 beats per minute during rest, is really not inferior to doing all these hijinks, all these things that we do to keep the heart rate under very strict control. Okay? So you will still see some of the physicians, some cardiologists who still believe in this old strict control method, and I think you can do that in a certain amount of the population. But in most of the elderly we see who are already on 20 medications, the last thing you want to do is to add the 23rd medication, 3 more medicines, and make their heart rate go down too low, make them dizzy, make them hypotensive, all because you're treating a number, not really looking at the patient themselves. So this study, I think, and most people agree, that lenient control is the way to go. Okay? So this has been a practice-changing study. This has been published in the New England Journal in 2010. The uptake has been a little low, but I think we're slowly but surely getting to where we would not worry too much about the heart rate itself. And really, this 110, remember, for those of us who work in the hospital, it's the same thing in the hospital. If a patient comes in with a pneumonia and their heart rate is 110 with atrial fibrillation, let's treat the pneumonia. Let's not get too excited about the heart rate, because the heart is just reacting to all the stress that's going on in the body. Okay? Now, how do we achieve rate control? These are the medications we use to achieve rate control. Okay? And these are medications all of us see all the time. We use beta blockers, we use diltiazem, we use verapamil. Verapamil is not as much used in the United States anymore. We basically use beta blockers and diltiazem, which is a calcium channel blocker. In rare patients, we use digoxin. So I said 3 medications. These are the 3 medications that we commonly use for rate control. Now remember, all of these medications have side effects. Beta blockers can make you tired and fatigued. Diltiazem can drop your blood pressure. Digoxin is a medication that needs careful monitoring. So you're adding to the complexity of a patient's care. If you can get by with one medication, achieving lenient rate control, I think that would be sufficient in most patients. Now, when we talk about atrial fibrillation, beyond the issue of whether we need to address the rate or the rhythm, the most important complication of atrial fibrillation is a stroke. What happens is that when the atria are fibrillating, the atria become they become a nidus for thrombus to form. So when your heart is not, when the atria is not contracting well, when it's fibrillating, you can have thrombosis within usually what is called the left atrial appendage that can dislodge, that can go up into the brain and cause a stroke. So that is really the most important complication of atrial fibrillation. Now, a few things have changed in how we assess the stroke risk. For most of us in the clinical realm, for years and years and years, we've used what's called the CHADS score to assess a patient's risk for having a stroke. And what's the CHADS score? The CHADS score gave you points for having congestive heart failure, hypertension, age more than 75, diabetes, or if you had a previous stroke. Okay? And most people believe that you scored 2 points or higher, you needed to be on an anticoagulant to keep your blood thin to reduce your risk of stroke. Okay? The problem with this score was that if you had a score of 0 to 1, okay, less than 2, you still had a reasonable chance of having a stroke, about 2% risk of stroke. And you can understand that 2% doesn't sound like a high risk thing, but it's a high stakes. A stroke is a high stakes game, not really a high risk game. So you really want to risk stratify people very, very efficiently and put people on the right drug. At the same time, not put people on a drug that could actually harm them. So now we've moved on to a score that is slightly much more complicated, but is much more useful clinically. And that's the CHADS-VASc score. What the CHADS-VASc score does is it gives us more points for if someone's age 65 to 74, that gives them 1 point. And here comes the old gender and atrial fibrillation again. If you're a female, you get 1 point because it appears that women with atrial fibrillation have a higher stroke risk. Okay? And the other thing that also changed is that if you have vascular disease, which is not part of the CHADS score, you got 1 point. Now, on the CHADS-VASc score, you can remember pretty much the same thing. If you have 2 or more points on a CHADS-VASc score and you have atrial fibrillation, an anticoagulant would be the way to go. Okay? So we should all be using the CHADS-VASc score to assess a patient's risk of stroke. Okay? Now, whenever you talk about thinning someone's blood, the first logical concern anyone would have is, what if they bleed? Because you're thinning someone's blood. And this is a score that you could use to assess someone's risk of bleeding while they're on anticoagulation. This is called the HAS-BLED score. Now, in this day of smartphones and apps, these are available on every single app that you can think of, cardiology-wise. There are calculators on the web. All you need to do is sit with a patient, put all these numbers in, and you'll get you'll even get a number that you can quote to the patient, an approximate risk. And I think that's very important in our discussions with our patients. Involve the patient in this risk discussion rather than just trying to be paternalistic and say, I think you need to be on a blood thinner. Okay. So the HAS-BLED score gives you an idea about the bleeding risk of the patient. Now, this is something I cannot emphasize enough. If a patient has a high bleeding risk, that does not mean you will back off from starting an anticoagulant. Because patients with a high bleeding risk also have a high stroke risk. All the bleeding risk is trying to tell you is, these are the risk factors. Is there anything I can do to modify those risk factors to decrease the risk of bleeding? Not really using this as a crutch to say, I think you'll bleed, I'm not going to start you on an anticoagulant. Remember, this would be the second pearl, if I can say that, is all patients at a high bleeding risk with atrial fibrillation also have a high stroke risk. So it's up to us to find the right medication and put them on the right medication to decrease that stroke stroke risk. Remember, these are very obvious. See, if you see stroke, it has 2 points on the stroke risk part. It has 1 point on the bleeding risk. Right? It makes sense that a lot of these factors are actually shared. So all you're going to do with this is choose the right medication by using these scores, not deny somebody an anticoagulant. The anticoagulant we've used for a long time was warfarin. Okay. All of us have heard of this or seen patients on this. You take this medication, you get regular blood work, you're given strict instructions on what you can eat, what you can't eat, on having a very stable diet. You have a lot of medications that you're supposed to avoid. And there is a reason why we go through all of that. On the x-axis here in this graph is the INR, or the internationalized normalized ratio. And on the y-axis is the odds risk of having an event. In the solid arrows here are for ischemic stroke, meaning a stroke that the atrial fibrillation caused because a blood clot went up to the brain, compared to bleeding in the brain because of the warfarin. So kind of the yin and yang of atrial fibrillation management. And this is what was found in a large cohort of patients. You really need to maintain that INR between 2 and 3. As you go lower than 2, your ischemic stroke risk goes up high. As you go just a little bit higher than 2.5, see this arrow here is 2.5, your bleeding risk goes up. Okay? This is one of the reasons why warfarin is such a tough drug to manage, is that its window is so narrow. The therapeutic window is so narrow. This being said, there is another important point to realize. This is the risk or the odds of having a stroke or the odds of having bleeding. If you looked at all the people who bled into their brains on warfarin, a majority of them will have it when they are between 2 and 3. So you can see how warfarin, though it's an effective drug in decreasing ischemic stroke, can predispose you to having a hemorrhagic stroke, bleeding into the brain. Okay? And because of that, we've been looking for alternatives for warfarin for a long time, because warfarin has all of these problems. Now, when we start looking for alternatives, I think it's very important for us to realize that as one ages, there are several changes in the body that affect how the same drug that would do something different in a younger person could act differently in an elderly patient. So as one ages, there is usually a reduction in lean body mass. There is decreased total body water. So if you have a lipophilic drug, the pharmacokinetics will be a little different. Okay? These patients are also on multiple drugs that they take along with any medication. So these drugs could interact at the level of the gut. They could interact at the level of the liver, where there is, either by the CYP mechanism or what have you, there could be interactions. And also, as one ages, the kidney function decreases. So excretion of the drug becomes a problem. So when we look at the direct anticoagulants after our break, which we'll take in the next couple of minutes, we will look at their role of these newer medications in the elderly and how and if these medications are safer than warfarin compared to, safer than warfarin in the elderly population.